This is an instructional video for the safe administration of intranasal dexmedetomidine, which has now been approved for use as a sedation agent for children over 1 year of age undergoing CT or MRI imaging at Royal United Hospitals, Bath. This video covers the administration process, preparation, and patient monitoring. The standard operating procedure can be found on the intranet under Anaesthetics or Paediatrics, providing additional information. This includes the method for calculating the correct dose, which is based on weight, and the weight should be recorded in the notes. Before any sedation is given, a pre-sedation assessment performer should be completed for the child, which can be found in Appendix 1 of the Standard Operating Procedure SOP. Dexmedetomidine comes in a standard preparation of 100 micrograms per ml. It should only be given intranasally for paediatric sedation and not via any other route of delivery. The standard dose is 3 to 4 micrograms per kilogram, up to a maximum of 200 micrograms. This should be given as a single dose 30 minutes prior to the imaging procedure. In children with obesity, the dose should be calculated according to adjusted body weight using the formula here. The dose of dexmedetomidine can be given either neat, with half the volume given into each nostril using a mucosal atomizing device. Alternatively, it can be diluted with 0.9% saline and half the volume administered into each nostril using the same device. It is recommended that at least 0.4 ml per nostril is given. In Appendix 4 of the SOP, there is a table with suggested doses and volumes according to the weight of the child. For example, in a 15 kg child, a dose of 50 micrograms can be given, which is 0.5 ml as a neat volume. This can be combined with 0.3 ml of 0.9% saline to reach a total of 0.8 ml, and then half of this, in other words 0.4 ml, given into each nostril. In order to draw up the dexmedetomidine, you will need a 1 ml syringe, filter needle, and a mucosal atomizing device. Once the correct dose of dexmedetomidine has been drawn up, attach the mucosal atomizing device to the syringe. Position the patient sitting up at 45 degrees or with their head turned to one side. Remember that half the dose should be given into each nostril. Place the device into the nostril and press the plunger quickly. Hold the device in place for a further 5 seconds to prevent medication leaking out, and then repeat the same on the other side. The aim is to achieve a moderate level of sedation where the child responds to command or responds briskly to a tap on the forehead. This responds to a 3 to 4 on the Ramsay sedation scale, which can be found in the SOP. Following a dose of sedation, the child should always be escorted by a nurse trained in paediatric life support, carrying a red bag with emergency equipment. Vital signs should be recorded at baseline and every 10 minutes throughout the whole process. If the child is more deeply sedated, then continuous monitoring is required as per the SOP. In the unlikely event of an emergency, a paediatric resus call should be put out, which will ensure both the anaesthetic and paediatric teams attend. At least 2 hours of monitoring post-administration of sedation is required as part of the recovery criteria. Some of this time may be monitoring on the paediatric area of day surgery unit. Patients can be safely discharged when they meet all of the criteria in the post-sedation discharge proforma found in Appendix 2 of the SOP. Patients can be discharged after 2 hours with routine advised post-sedation given verbally and in written form to the patient's carer. Please read the online SOP for more information on alternatives to sedation, contraindications and exclusion criteria. Thank you for listening.